Financial Management Association. She's involved in many healthcare and legal professional organizations. She's a frequent speaker both in Colorado and nationally, as well as a university instructor on legal issues affecting the healthcare industry. So let's all welcome Ellen.
Good morning. I'm delighted to be here again. This is part 2, I guess, of healthcare reform, talking to you about healthcare reform, and this is a little loud, so maybe they can turn the mic down just a little. I'm with the law firm of Berenbaum Weinshienk in Denver, and I've brought along this time, because healthcare reform is so complicated, I brought with me some of the brain trust at Berenbaum Weinshienk. So when we get to the question and answer period, if there are questions I can't answer, hopefully one of my partners who are here will be able to do that. And so I'll just introduce them to you before we get started. Mike Bello is sitting on the end right there. Mike does employment law. Next to him is Steve Rickles, who is an expert in ERISA, the Employee Retirement Income Security Act, which I think some ERISA lawyers say every ridiculous idea since Adam. But Steve is the brain trust there. Next to him is Ken Kramer. Ken is an expert in real estate and property tax appeals, which some of you may have been going through in the last couple of years. And finally, next to him is David Miller. And David is a bankruptcy lawyer. Not that any of you are going to need to know that, but interestingly enough, in the bankruptcy code, there are some issues when healthcare providers file bankruptcy. There's some interesting little twists there. So I thought I'd bring them along and introduce them to you. So if you have specific questions, they're going to be, I think, hanging around too and can answer some of them as well. So we're going to talk about healthcare reform, and I thought we'd discuss where we are now, sort of what the required benefit changes are, what some of the penalties are. We'll talk a little bit about accountable care organizations, because we're seeing more and more of those come into place. We'll talk about rebate calculations. These are premium rebate calculations that have been in effect now for 2 years. So some of you may have gotten premium rebate checks again this year, as well as the prior year. They generally came out this month in August. We'll talk about a little bit about grandfathering plans and some new requirements for ERISA plans, so self-funded plans. The Affordable Care Act actually made ERISA plans look a lot more like traditional insurance plans in terms of appeal rights of employees when they have a claim that's being denied. So we'll talk about it from the claim denial perspective. Then we're going to talk about some of the next steps in 2014 and beyond, because those of you who've been listening to the news know that there have been some changes. And then most importantly, we're going to talk about the health benefit exchange in Colorado called Connect for Colorado, which will be up and running October 1st. It is on time, unlike some of the others that aren't. Our health exchange in Colorado will be open, will be on time, beginning October 1st for individuals to be able to purchase insurance through the exchange effective January 1 of 2014. So that's sort of what we're going to try and cover. And I understand that, again, that this outline, if you want it, is available, and Allison can email it to you. So let's talk about what happened the first plan year after September of 2010. It doesn't seem like it's been that long since the Affordable Care Act went into place, does it? I mean, it seems like it just happened yesterday, and that's probably because we're still hearing about it, including today. As I was driving in, NPR was doing a story on the Affordable Care Act, saying that there's still people who are looking to defund the act, saying that the cost of it is prohibited and hadn't been well budgeted. So you know, hold on to your hats. We could be doing all this and then it could all go away. Except in Colorado, Colorado has made the decision that regardless of what the federal government does regarding these health benefit exchanges and the Affordable Care Act, Colorado will continue to have their health benefit exchange. So, as you all know now, You get coverage up to the age of 26 or the end of the year in which you turn 26, regardless of tax dependency or marriage. This is for dependents. So if you have a kid, they can now be covered up to the age 26. Another thing is that there are no retroactive rescissions or they can't take away your coverage unless there's intentional fraud. And there's some things specifically that they have to prove intentional fraud. And then there's a prohibition on lifetime limits on essential benefits. So for example, inpatient hospital care is an essential benefit. Many of you have had plans which had $1 million lifetime maximum. Those lifetime maximums have gone away as of January 1. And you can see the restrictions that were permitted in 2011, 12. This year, it's the lifetime max is, the restriction is $2 million, but after that, it's unlimited. So there will be no lifetime maximum. So if you have someone that has a debilitating illness that they've had that's anticipated to be through their lifetime, there is no lifetime maximum anymore. This was really problematic, especially for kids, because if you have a kid that has some problems when they're born, they can rack up bills in a hospital of over $1 million very, very quickly, depending on the type of their illness. And so doing away with this lifetime maximum is going to be very helpful. There are also no pre-existing condition exclusions for kids under the age of 19. The next, again, in 2010, there has to be coverage of preventive health care services and immunizations. And so when you go in for your annual exam, your doctor will most likely ask you, as mine did to me, do you want this to be your annual exam, which means that you don't have a co-payment or a deductible when it's your annual exam. And that's new, that the health insurance that you have has to pay for that. There can be no requirement for pre-authorization of an emergency. Now, that's been the law in Colorado for a long, long time. Can you imagine having to call your health plan? Your spouse is having a heart attack, they're on the floor, you have to call your health plan first before you call 911. Didn't make sense at all. So under the Affordable Care Act, that requirement, any requirement that somebody would have to get authorization for calling 911 or calling your health plan first to get 911 authorized, that's gone away. And the cost sharing has to be the same if you're an in-network or an out-of-network. If you go in-network to an emergency room that's in your insurance network, or if you go out-of-network, same cost sharing. So if, for example, you are on vacation in Arizona and God forbid something happens and you have to go to the emergency room, you'll pay the same percentage in terms of deductibles and coinsurance that you would if you went to an emergency room in Denver that was within your plan. Okay, so that's another thing that happened. People can now choose their own primary care provider, and OBGYNs and pediatricians are deemed to be primary care providers. Pediatricians, I think everybody thought were primary care. But for women, OBGYNs often were not considered primary care providers. Now they are. So you don't need a referral to go to a primary care provider. And there was a one-year compliance period in 2010 for health plans and insurance companies to comply with appeals and reviews. And this is a really important benefit for the individual, these appeals and reviews. Okay, so what happened in 2011? That was 2010. Now we're in 2011, 2 years ago. The non-discrimination rules for insured plans came into effect, which could affect post-employment executive agreements. Those are often known as severance agreements, where someone leaves employment and they have a severance option. There were some rules that came into effect in 2011 for that. The value of your health coverage had to be reported on W-2s in 2011. So all the employers are now reporting the value that they pay for your health insurance premium on your W-2. So if you look at your W-2, I mean, I tend not to, but if you do, you'll see that the amount of the health insurance that was paid for you by the employer is now on your W-2 form. So that's another change. It's no longer permissible to reimburse OTC, over-the-counter drugs, without a prescription. That includes insulin, and that's, you can't any longer reimburse over-the-counter drugs from your flexible spending accounts or your health spending accounts or your health reimbursement accounts. So all of those types of accounts before, you know, everybody, I can remember people run into Walgreens to get all their receipts at the end of the year, to submit their receipts to HR so that they could get the last dollars out of their plans. And they'd buy aspirin and all kinds of things over the counter. That's gone. You must have a prescription now in order to get those reimbursed. And finally, in 2011, eligible small businesses and nonprofits could claim a health care tax credit on their 2010 business taxes. So that's also been a help for small businesses and for nonprofits. And interestingly, nonprofits are treated differently in the Affordable Care Act. So if you're a nonprofit employer, there is some different treatment of nonprofits because nonprofits generally don't pay tax. And so they're treated a little bit differently, and we'll talk about why that is in a minute. Okay, 2012 and 2013. In 2012, your 990s had to be issued for payments made to another person in the trade or business that in aggregate was over $600 or more in any tax year. Those 990s, basically they wanted to determine if somebody was acting like an independent contractor or an employee. They wanted to capture those payments as well. And then as of January of this year, there's a $2,500 cap on contributions to flexible savings accounts. So before there wasn't the cap, now there is the cap of $2,500. So that went into effect for those that have flexible spending accounts under a cafeteria plan. So now we get to 2014. This is January 1. Individuals are required to maintain minimum essential coverage for themselves and dependents. Employees have to do that, individuals have to do that, or they have to pay a penalty. So that penalty does go into effect on January 1. So if you don't have health insurance on January 1, unless you're in some special category, which there aren't very many, like you're incarcerated or you're on, if you're on Medicaid, you're deemed to have insurance. There are some special classes of folks that aren't required, but generally, the general population, everyone is required to have health insurance by January 1. Or if you don't have it, you pay a penalty. Now, the interesting thing about the penalty for individuals is that penalty is going to be collected by the Internal Revenue Service. So when you fill out your annual tax return and you submit it to the government, if you don't have health insurance and you have a refund coming, you can kiss that refund bye-bye up to the cost of what is paid for you, would be paid for you to have health insurance. And I think there's a maximum of, what, $600 and some odd dollars. So if you don't have health insurance, you're going to pay a penalty, and the IRS can take that penalty from you through your tax refund. So you say, well, I don't have a tax refund coming, and I don't have health insurance. So what can the IRS do? Well, normally, if you don't pay taxes when they're due, the IRS can do a lot of things to you, right? There's a lot they can do to you. They can seize your property, they can sell your property, they can levy your income, they can put liens on stuff. You know, the IRS is very powerful. They're not people you really want to mess with. That's sort of my take on it. So but they can't do any of those enforcements to collect this health care penalty. They can't lien your business, they can't lien your income. It just sits out there until you got some money that they can go after and then collect. But otherwise they can't go in and, you know, insert themselves into lawsuits. If you happen to have a lawsuit where you're going to get money out of that lawsuit, they can't go in and file claims in that lawsuit to get paid first. None of the things that they can normally do to try and collect taxes, they can't do that to that penalty. So if you're somebody that's sort of on the line and you know, have enough withheld and you file your tax return and there's nothing that you get back, then there's nothing that they can do to come back and enforce that penalty against you until you make some money. So the second penalties apply to large employers. And large employers are more than 50 full-time equivalents, excluding seasonal employees who work less than 120 days during the year. And a full-time equivalent must work 30 hours per week. So there's sort of this formula that you've got to calculate to see if you in fact are a large employer. Because for small employers, the penalty doesn't apply. So if you're less than 50, you don't have this penalty that applies. If you're more than 50 employees, then you do. And so if you're a large employer, you have to pay a penalty if a full-time employee receives subsidized coverage through the health benefit exchange. So let me go and talk a little bit about the healthcare benefit exchange. That benefit exchange works like Expedia.com or like Travelocity.com. And for those of you who've used those, or like, who's the guy that, William Shatner, Priceline, doesn't he do Priceline.com? And he's the guy that gets up there and says, you know, if you're looking for cheap airfare or a hotel or a rental car, go on Priceline.com and we'll tell you everything that's available and then you can pick. Well, the health benefit exchange works similarly, if not almost exactly like that, with one small difference, and that is there's real live people help if you get in trouble. Those people are called navigators. And so health benefit exchange will have folks that are there to help you if you get stuck when you're trying to make a decision about which insurance plan should I choose. Should I choose the bronze, the silver, the gold plan? Which of all of these plans that are offered under the exchange do I want to choose? And then they'll be there, the navigators will be there to help individuals when they go online. Now, my advice to you is do not go online October 1st, because the world is going to go on the benefit exchange October 1st. We do not want to crash the Colorado system, right? However, you can go online now and kind of look at the exchange website to kind of get a sense of the look and feel of it. And I'll give you, later in the presentation, I have the web address for that. So you can go on there and sort of get an idea about how that works. Well, originally under the Affordable Care Act, these penalties for these large employers were supposed to go into effect on January 1 of 2014. The feds aren't ready for them. They're not ready to do it, so they've postponed it for another year. So the penalties, if you're a large employer group, the penalties don't apply until January 1 of 2015. The requirements, however, to provide affordable care coverage still are in the law, and I don't know how they're going to balance the requirement for you to have an affordable plan that provides a minimal amount of coverage, but there's no penalty if you don't provide it. So people are now looking at this, their plans. If they're large employers, they're looking at their plans. The other thing I wanted to mention about the health benefit exchange, for those of you that are employers, you're required to send a notice to all your employees by October 1st, telling them about the benefit exchange. So you have to send them a notice, and you have to send it to all your current employees, and then you have to send the same notice to every new employee that comes on after October 1st. So you want to make sure that you get these notices put together, and again, there are samples of notices all over the place that I'll again show you how you can get the sample notice to give to your employee, but a lot of those notices are specific to your plan. So you have to look at what your health insurance plan is and give the notices to the employees about what your plan covers. Okay, so let's talk about some of the penalties that have been postponed. So basically, if you do not provide a plan that has minimum value and affordability, then you have to pay, and minimum coverage, then you have to pay the penalty. So what they've said is, and I put in the slide the calculation about how that works. But basically, the penalty is if any of your employees, and you're a large employer, go and receive a premium credit when they go on the health benefit exchange, then you're going to be subject to a penalty as the employer, which means that you're not providing a plan that has minimum value or is affordable and or provides the minimum coverage required under the Affordable Care Act. So again, those penalties have been postponed. You also will have a penalty if the amount of the employee contribution for coverage exceeds 9.5% of the employee's household income, or if the plan pays for less than 60% of covered expenses. So if you have a high deductible plan that covers less than 60% of the expenses, then you've got an issue. If you've got a plan that's in place, but your employees pay a huge amount of money for that plan, then you may also have an issue. So how do you know whether you have an issue, right? Well, the best way is to contact your insurance broker and have them run through the analysis for you, or a third-party administrator if you're a self-insured plan. Have them run through the analysis for you so you can see if you actually have any penalties that you're going to have to pay. They're the experts out there, and I know that they're meeting with a lot of large employer groups just to look at what their coverage is, look at what the premiums are, and see that the employees pay, and see if they're going to be in one of these categories. Now, small employers are not affected, but a small employer can receive a tax credit if it meets certain requirements, and when we get to the health benefit exchange topic, I'll talk about what those credits are. So, accountable care organizations, what are these things? Well, there's accountable care organizations in reality, the real ones, and then there are the ones that people are saying, I have an accountable care organization, and there's a difference. So accountable care organizations were designed to provide coordinated care for Medicare beneficiaries. That's what they were designed to do. The federal government gave about, I want to say, 70 or 80 grants across the country to organizations to help them create these accountable care organizations. And in Colorado, we have one of the pioneers in this accountable care organizations, and that's Physician Health Partners. Physician Health Partners is a group of physicians that have come together. They are a lot of specialists in geriatric medicine, and they are they're based, I think, their corporate offices are downtown, but they have offices all over the Denver metro area, and these physicians have a contract through Physician Health Partners with the feds to provide coordinated care for Medicare enrollees. Now, the interesting thing about this is not only do they have to provide coordinated care, but they also have to meet 36 quality indicators. A big part of the Affordable Care Act was a push toward quality, a push toward making sure if you go to your doctor, they're providing quality care to you in the physician's office, making sure that hospitals meet certain quality of care standards, and if hospitals don't, they are penalized in reduced payments from Medicare. So quality is a huge issue under the Affordable Care Act, and you'll see a lot of information coming out about people meeting the quality care indicators. So the accountable care organizations, the ones that have the contract with the federal government, those are up and running and are now seeing patients. There are some organizations that call themselves accountable care organizations. Those are accountable care organizations light, as I call them, because they don't have the contract with Medicare, but they're trying to put together a system so that when these organizations of doctors and hospitals go in contract with the insurance companies, they can say to the insurance company, I've got quality of care, I can help manage the cost in my organization. And our organization is going to be accountable for the care that we render. So there are two different types, and sometimes they get interchanged and confused. All right, so rebate calculations. Have any of you gotten rebates? Have anybody received a premium rebate? You would have gotten it, you did. Were you surprised? No. So the reason, I've got the calculations in the slides and you can go through those, but the reason that you're getting a rebate is because your insurance company is making too much profit. So insurance companies are now limited to what they can make in terms of profit. They have to provide, in the premium that you all pay, insurance companies have to provide 80%, and I think it got indexed up this last year, they have to provide at least 80% of your premium that you pay overall has to go towards paying for the cost of medical care. So that means if you pay $100 in a premium, $80 of that has to go to pay for medical care, plus quality improvement stuff and the like. But it can't go to the insurance company's pocket now, which is why companies are now getting rebates. Companies are getting rebates and individuals are getting rebates as well. So I've put the rebate calculations in there. I'm going to skip over them because you can all read them in the handouts. So rebate calculations aren't going away. They're indexed every year. It looks like they're going to ratchet up the cost that the percentage that health plans, that insurance plans have to pay for medical costs, so that's good for the consumer. That just means insurance companies have to spend more of their dollars making sure that you get good care. Okay, so ERISA, there were a number of changes in ERISA. Every ridiculous idea since Adam. I just love that. I just love it. You probably don't like that, Steve, do you? That's what I call it.
I pretend I'm amused.
You pretend you're amused, thanks. So there are some substantive benefit changes that apply to group health plans for those of you who have self-insurance plans for your employees. These requirements don't apply to standalone dental and vision plans if you're self-insured for those, or retiree-only plans. Those are excluded. And there are different benefit changes that apply if you're a plan that's grandfathered or not grandfathered. And don't listen because I'm going to simplify this, but basically if you had a plan that was in place in 2010 and you don't make any changes to it, then it's a grandfathered plan. But the minute you make changes to it, it ceases to be grandfathered. I mean, at the very basic, by now, probably most plans aren't going to be grandfathered. Very few, I think, will be grandfathered in. Basically, under the grandfathering, you can see what the requirements are. So, originally, it appeared that plans wanted to be grandfathered, but now, upon the issuance of regulations, there's not a large impact if you lose grandfathering, so people aren't that concerned, I guess, that they've lost grandfathering. And then there are the requirements if you lose grandfathering. And again, if you have a self-funded ERISA plan, I'd encourage you to get the handout from Allison, and she can give this to you so you can see what what triggers the loss of grandfathering of your self-insured plan. So let's see. Under ERISA now also, one of the things as a healthcare lawyer that has sort of always bothered me is that health insurance plans, your regular health insurance plans, Anthem, Cigna, Anthem Blue Cross, Cigna, United, those regular insurances, I call them, were regulated by the state of Colorado, the Division of Insurance. They regulated those plans, and there's lots of state laws about what those plans have to cover in terms of benefits and how claims have to be paid and what your rights are for an appeal. Under ERISA, though, there was nothing. It was sort of like this wasteland, no real teeth to anything, no prompt payment provisions. You know, there was kind of like, well, you should pay the claim within this amount of time, but nothing that from the provider side that they could really go after, nothing. So for me, it was lovely when the Affordable Care Act came into place because I represent a lot of providers. And so now the providers have a little bit more teeth when they're going after these ERISA plans to try and get their claims paid. Or if the ERISA plans were denying coverage, which they sometimes did as well. Now, interestingly, under the Affordable Care Act, there are all kinds of requirements for ERISA plans that look very much like what normal insured plans have had to do all along. You know, you gotta, if you're gonna deny a claim, you gotta let people know right away if they're in the hospital and their doc says, you need an MRI, and if you have to get an MRI authorized, the health plan doesn't get to sit around and twiddle their thumbs waiting on authorization. They have to give an authorization quickly. And the nicest part about this that applies to both insurance plans and ERISA plans is now if you appeal a denial decision under the Affordable Care Act, you're not just appealing it to somebody at the health plan or somebody at the insurance company, right? A panel of all the insurance company docs. Now, under the law, you have the right to an external review. And there are two types of external review. There's a federal external review and a state external review process. Colorado has had for many, many years, as part of the insurance regulations, an external review process. So if you didn't like the decision that the health plan made about your health care, you could go get it reviewed externally. Now, folks, including ERISA plans, are required to have that as an option. Either the external, and they can use different external reviews, and a lot of the ERISA plans are going with independent external review options. And I think this next slide shows only 5 states do not have an external review process currently. So most of the states had this anyway for their insured products, and now ERISA plans have to comply with this as well. There are a number of different rules. If you have an appeal or you think you need to appeal an adverse decision regarding coverage, you as the patient, you have up to 4 months after you receive the determination to file your appeal. A lot of times these plans said you had 30 days. If you didn't appeal within 30 days, your claim was lost. Now you have up to 4 months by the law. The plan has deadlines upon which they have to do the review for the preliminary review. And then these independent review organizations, if you decide to go with them, they don't just take the file from the plan and look at it. They have to and say, oh yeah, that decision looked reasonable. They've got to start from scratch. They've got to start from the beginning, look at all of the information, and then make a decision. That's called a de novo review. And they have to, these independent review organizations have to decide in 24 or 72 hours, depending on whether it's an emergency type of situation for which they gave a denial or a non-emergency. So they have to do it really, really, really quickly. These independent review organizations, they have to be independent. You can use more than, you're supposed to use, I think, 3, rotate the claims through those 3. And interestingly enough, TPAs or third-party administrators, they also now have to comply with the process for appeals. Okay, health benefit exchanges. Colorado's benefit exchange is called Connect for Colorado. It's got a great group of very smart, dedicated people who have worked tirelessly in the last 2 years to put this thing together. And I think, personally, they've done an excellent job. It's amazing. The health benefit exchanges were required to be in place by January 1 if states were going to do them. Many states, more than half, I think at last count 39 states, somewhere around there, do not have their own health benefit exchange. They've opted to use the federal government's health benefit exchange. We in Colorado, though, have our own. And that's a good thing for us, because in Colorado, our exchange has been able to be much more flexible, be much more creative in what they do, and look at products that are geared to the people in Colorado as opposed to somebody that's in Atlantic City or that's in San Diego, California. We've been able to design and work, our exchange has been able to be designed to meet the needs of people in Colorado. And they did get a bunch of money from the feds. Colorado got a bunch of money from the feds to set up the exchange, and they just got a new grant, I think last month, of an additional $11 million from the federal government to help get this exchange finally up and running. Now, the problem with the exchange at the federal level is, for those of you who have businesses that are in more than one state, the federal exchanges have created a huge issue because the exchange, health benefit exchange, needs to talk to the state Medicaid system. And every state Medicaid system is different, because Medicaid, while it's funded 50% by the federal government, it is a state program, state contracts to do the IT work, to determine eligibility. So these exchanges now have to be able to talk to the state and say, if a person comes on the exchange and they put in certain information and it's determined that they're eligible for Medicaid, then they need to get over to Medicaid, right? As opposed to being on the exchange. And with the Medicaid expansion, Medicaid will now go up to, I think, 133% of the federal poverty limit. So if you go on the exchange and you're a family of four, less than 133% of the federal poverty limit, then you are potentially eligible for Medicaid. So you sort of come out of the exchange and you go over into Medicaid, and the Medicaid people help you enroll. If you are not eligible for Medicaid, and you're a family of four, and you make up to $92,000 a year, you may be eligible for a subsidy through the exchange for your health insurance premium. And so the navigators will help you do that. The interesting thing in Colorado, let's see. The interesting thing I think I have it on the next slide. There it is. In Colorado, and there's the website, connectforhealthco.com is the Colorado exchange. Our exchange, they're working very, very carefully to make sure that there is this good communication between the health benefit exchange and Medicaid, and that the navigators, when you get on, if you are eligible for some kind of a premium rebate, or if you're eligible for this subsidy, then you can calculate it actually on the website. The Health Benefits Exchange in Colorado sent out RFPs to health plans saying who wants to offer insurance through the exchange. They originally got 17 different carriers saying that they wanted to offer coverage through the exchange. And these are the carriers that have been accepted preliminarily. The Division of Insurance hasn't quite finished its review, but preliminarily, these are the carriers that are going to be offering coverage in Colorado. Some of them you may not be familiar with. Some of them are organizations that were created just to write insurance on the exchange. But you'll see some of the old the old favorites, Anthem and Cigna and Kaiser and Humana and Rocky Mountain Health Plans and United, although United is actually offering their product through a subsidiary, not through United Healthcare. So these are the plans that submitted there were 17 plans. These are the ones that got down to the finalists. So there's an organization called the Colorado Consumer Health Initiative. They're real good. They're out there sort of advocating for consumers, and they did an analysis of the RFPs that were submitted by the insurance companies, and everybody had to submit their RFP based on a set design premium package, benefit package. So it had to include outpatient care and inpatient care and emergency and pharmacy, and so there were a whole list of things that it had to include. Minimum basic benefits for the different plans, and there's a bronze plan and a silver plan and a gold plan, and I think there may even be a platinum plan. Well, the Colorado Consumer Health Initiative took all of these plan proposals that came in with the RFPs, and they have now determined what the rates are. So in Denver, if you are 27 years old, your premium would be between $207 and $373 per month. If you are 40 years old, the premium is from $253 to $454 per month, so it's more expensive. And under a family plan, $756 to $1,360 per month for coverage. So now think about what you're paying. These are the rates for Denver, and it's the Denver metro area. You can see the Durango rates, the analysis that CCHI did included the Durango rates. The one that I thought that was most interesting, though, was the Fort Collins rate. So if you were a 27-year-old, your rate would be $197 to $406 per month. $197 per month? That's pretty amazing, isn't it, in terms of an insurance premium? I think it's fantastic. Can't tell you why it's so low in Fort Collins for a 27-year-old. Have no idea why in Fort Collins it's less than Denver at 207 or Durango. Have no idea why, but that's the analysis, and so Fort Collins ended up being the better place. Yes, you had a question.
How many children?
The question was how many children. Well, if you have children, it's the family plan.
12 children?
For the family, it says 2 parents, age 40, and children under 18. Pardon?
1 to a million children is the same?
1, 2, or a million children. Don't know. This is just the aggregate data. These are not the final rates. Okay, so we don't know based on how many children you have what the rates are in this study. And I quite frankly haven't looked at it because there were 800 different proposals submitted by the 17 carriers, and not all 17 carriers were accepted into the plan. And the Division of Insurance hasn't accepted these rates yet. This was just based on the proposals that were submitted. There was another question here. Yes?
Obviously, there's going to be more different age differentiations.
Yes, the question is obviously there's going to be more age differential. Right. They just picked out a sample when CCHI was doing the analysis. They picked out a sample. The question is, are the filings available? They are, because the Colorado Consumer Health Initiative got them. So you can go to the Colorado Consumer Health Initiative website and you can see their study. Yes, ma'am, in the back. Okay, so are these new rates, or because she just did one for a 27-year-old in Denver and they were a lot less? Yes, these are the rates under the exchange effective January 1 of 2014. So these are the rates. If you go through the exchange, these are the rates that the plans have offered. But remember, rates differ depending on what kind of coverage you're getting. And this is a basic coverage plan that may be more than the coverage plan that you were looking at for your 27-year-old. Okay, so you have to look at what the benefits are, compare the benefits, and then compare the premiums. But under the exchange, these were the ones that were initially submitted. Okay. So the interesting thing about the Colorado Health Benefit Exchange is if you go on the website and you are a business, a small employer, and you want to know whether you're eligible for a tax credit, the Health Benefit Exchange has a calculator there, so you can put in your employees, you can put in what you pay them, you can put in the cost of the health insurance, and it will come out with a number if you are at all eligible for any premium tax credit as an employer. So basically, if you have fewer than 25 employees who earn an average of less than $50,000 a year, you will probably be eligible for some kind of a tax credit. The nice thing that the Benefit Exchange does also for small businesses is that it has frequently asked questions, including sample letters that you can send to your employees. That's very helpful. I think notifying them about the exchange. It also talks about what the effect is on COBRA. If you have somebody that's going on COBRA, how does that tie into the exchange? The Colorado Exchange also has information for individuals. So if you are an individual and you want to know whether or not you're going to be eligible for some kind of a subsidy, there's a calculation to determine the amount of the subsidy you may be entitled to. So you can fill in your income, fill in the number of people in your family, and fill in your, I think that's it. And then it'll calculate it through and it'll give you the amount of the premium subsidy that you're you're entitled to under the Benefit Exchange. One little thing here is that the interesting thing about this Benefit Exchange is that now, currently, everyone is on the honor system regarding what your income is. So in order to be eligible for a premium, and whether you go, if you're in that 133% up to 400% of the federal poverty limit, if you're in there and you put in the income, you are on the honor system. There's no, today, system to go and verify your income with your tax return. The system doesn't exist to be able to do that. Now, if you get kicked over into the Medicaid side because you're at 133% or less, then Medicaid does have a procedure that you have to go through to qualify for Medicaid, and then they will verify income. But on the Health Benefit Exchange side, there is no verification today. That doesn't mean that in the future, they won't get that together and the states won't communicate with the IRS to make sure that in fact you're not lying about your income. But currently there's no ability to do that, and there's no real system that's been put in place to detect that fraud. Now, I'm telling you that, but don't lie about your income to get a subsidy. Because eventually there will be the connection and they will come after you, because that's insurance fraud. Okay, ma'am.
Where does the subsidy come from? Colorado government or federal?
The question is, where does the subsidy come from? The Colorado government or the federal? It comes from a combination of both. But at the beginning, it's the federal government that's going to pay it. Pardon? Oh, how is the subsidy paid out? The subsidy will actually be paid to the insurance company. So the insurance, you sign up, and whatever your subsidy is, that amount is paid to the insurance company. It's not paid to you. You don't get it. It's paid to through the exchange to your insurance carrier. I'm sorry, the question is, does that reduce the premium? And the answer is yes, it would reduce the amount of your subsidy reduces the overall premium that you as an individual would pay. So you go online, you choose a plan, it says your premium for that plan is $1,000, but you're entitled to a subsidy of $200. That means your ultimate premium is $800. So you write a check for the $800, and the $200 gets paid over to the insurance company by the exchange. Yes, ma'am, Allison. Oh, I'm had 5 minutes, okay. I thought maybe she had a question. All right. That was good. So some people who are participating in Cover Colorado, you know, Cover Colorado is the program that's been in the state to provide insurance for an insurance marketplace for those people who had a pre-existing condition or could not otherwise get insurance. Cover Colorado is going away in January. There is a transition period right now from Cover Colorado to get us covered. But this is basically a transition of those people who are currently enrolled in Cover Colorado until they can transition those folks into the health benefit exchange. And again, the health benefit exchange will have in Colorado, nationally they call them navigators. In Colorado, we're going to call them health coverage guides. So when you get on the benefit exchange, there'll be a health coverage guide who will help you select what kind of coverage might be best for you. Again, I wouldn't call on October 1 because I think those poor guides are going to be swamped with questions on October 1. And remember, there are 3 months. You have October, November, December to actually get your health insurance so that it's actually available by January 1. Okay, sorry. Done. I had 5 minutes, I'm finished. So now officially questions. Anybody have any questions? Yes, ma'am.
On the Colorado Health Exchange, only individuals can ask for health insurance, not not small businesses.
Okay, so the question is, under the Colorado Health Benefit Exchange, only individuals can get information, not small businesses. Small businesses can also get information on the exchange. There's a small business product that they have now on the exchange as well. So small businesses can go on the exchange when the products are up and see what the products are that are available. Okay, sir.
So speaking of small businesses that currently offer health benefits, can they eliminate their current offering, provide some form of compensation to offset to their employees, maybe through an HRA, allowing employees to go shop on the exchange and potentially get some subsidies and pick their own insurance?
Okay, so the question is, I'm a small business, so I don't have penalties, remember, because the penalties only apply to large employers, not small employers. So I'm a small employer, and I'm currently providing health insurance for my employees. Can I not provide that health insurance, have the employees go and get their insurance on the health benefit exchange, and then to help the employees pay for that, maybe increase their income a little bit to help them get the premium, pay for the premium on the exchange. But then the employee would be also eligible potentially for a subsidy on the exchange. And the answer is, can you do that? Yes, I think you can do that. If you're a small business, I think you can do that. However, you're going to have to be very careful about the calculation to make sure that your employees don't get adversely affected by this going to the benefit exchange. And remember, these things, the poverty percentage stays the same, but what is 400% of the federal poverty limit may vary because those calculations are done annually, so that may vary in terms of whether they qualify. So there are some tricks in it, and they may not all get the same subsidy because it depends on, are they an individual, is it a family? So it might work, but there's a bunch of number crunching, I think, that would have to go through before somebody would make that decision.
Can they use an HRA? Can an employer use an HRA?
So the question is, can an employer use an HRA? And I don't know in that instance whether they can. So I would defer you to either Mr. Rickles here, who can maybe answer the question, or Mr. Weinstein over in the corner, Steve Weinstein in the corner, also an ERISA expert, to answer that particular question. Hopefully they can tell you. Sir?
On the rates that were referred to, is there a benefit deductible, a copay, is that a level playing field? Is everyone
Okay, so the question is on these premiums, is there a deductible or their coinsurance? Is everyone on a level playing field? And the answer is yes. Everyone is on a level playing field, and the benefits, the coinsurance and deductibles vary by plan just like they do today. They vary by plan. The thing that they have to provide is a minimum essential plan. Colorado, when it went to go and do the RFPs, selected the Kaiser Health Plan basic plan as the minimum benefits that have to be covered. But yes, there can be changes in deductibles and coinsurance, though there can be changes depending on the type of the plan that you have, and the premiums will be adjusted as well. So yes, there can be deductibles and coinsurance. It's not, unless, I'm assuming there'll probably be a closed panel HMO option, so like a Kaiser option, where you have to go to Kaiser. And then, of course, with those options, your coinsurance and deductibles are going to be a whole lot less. But there is a basic cap on them, and they're going to take into consideration what the coinsurance and deductible is when they're looking at the premium. Okay? So, yes, and remember, there are 800 different plans that were submitted. So I can't tell you what every plan looks like, and the Division of Insurance hasn't approved those plans yet, so I can't tell you about that. Yes, sir, in the back.
All the way back to one of your earlier slides, there was a calculation on what are the penalties that are going to kick in 2015. It had to do with the maximum 95% of household income.
Correct.
In the world will they monitor that when you have an employee who you know what their income is? You have no clue about the self-employed spouse who's on variable income.
Right. The question is, how are we going to monitor household income on the penalty for the large employers when they have to pay a penalty? And that's one of the things that we don't know about. The IRS is trying to figure it out. I think that's part of the reason that they postponed the penalty, because there's going to have to be some reporting back to the employer, and that raises a whole bunch of issues. So more to come, more regulations to come. Okay, so our time is up. If you have questions afterwards, I'm going to hang around, and like I said, I brought with me the Brain Trust here, so feel free to ask them questions as well, and thank you, Allison, for having me attend again.